Hello, welcome to Building Blocks of IPC. This telementoring series is a part of Project First Line, CDC's National Training Collaborative for Infection Prevention and Control. In the AMA's work with Project First Line, we have heard from physicians and other healthcare professionals that there are significant challenges in facilities outside the acute hospital setting, places like ambulatory surgery centers, pediatric offices, and behavioral health facilities, to name a few. To help meet these challenges, we developed this telementoring series, bringing together physicians from these settings with IPC experts from across the country. This session will focus on some IPC questions that can arise within post-acute long-term care centers. These facilities have unique challenges. Many residents are elderly with multiple comorbidities. Group therapies and activities are a large part of the community, and welcoming in outside visitors offers great benefits to the people who live there. Today, we have outlined a few discussion questions based on situations that have arisen at one such center. Before I move on to these questions and what is sure to be an interesting discussion, I'd like to remind everyone that the opinions expressed in this session are those of the presenters only and do not necessarily reflect the official position of the American Medical Association, U.S. Department of Health and Human Services, Centers for Disease Control and Prevention, or the presenters' affiliated institutions. I'd like to go through some ground rules for all these sessions. First, this is a share all, learn all format, so judging is not appropriate. It's okay to disagree, and those disagreements often lead to great discussion. Many of the questions we discuss today will highlight some gray areas of infection prevention, but we always want our words and language to remain respectful. For those of you joining in chat and asking questions, please introduce yourself, note the state you work in, and your occupation. We want to tailor our answers to what is most helpful to you. And lastly, please do not put any PHI in the chat. Just keep your questions general. I'd like to introduce myself. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. I am the physician lead on Project First Line and continue to practice infectious diseases in Indiana. Now I'm thrilled to introduce the panel we have today. Our presenter, Dr. Leslie Beth Eber, is board certified in internal medicine and is a certified medical director. She has provided medical directorships for both long-term care facilities and hospice and is currently the medical director for multiple facilities. She serves as the chief faculty for Abode Care Partners. Dr. Eber is on the national board of AMDA, the Society for Post-Acute and Long-Term Care Medicine, and is the clinical advisor for the AMDA and CDC collaborative, Moving Needles. Dr. Eber was awarded the AMDA Medical Director of the Year for 2021 and has provided expertise for several national initiatives and presented for at the ECHO COVID-19 Global Conversations, Vaccine Development, Distribution, and Delivery. Our subject matter experts are Dr. Priya Nori and Dr. Margaret Fitzpatrick. Dr. Nori is the Medical Director of Antimicrobial Stewardship at the Montefiore Health System in the Bronx, New York, and the chair of the SHEA Stewardship Committee and deputy editor of the SHEA Journal, Antimicrobial Stewardship and Healthcare Epidemiology. Dr. Fitzpatrick is an associate professor of medicine in the Division of Infectious Diseases at the University of Colorado School of Medicine. Dr. Fitzpatrick is an infectious diseases physician and researcher at the University of Colorado and the VA Eastern Colorado Healthcare System in Aurora, Colorado. Her research work studies the epidemiology and prevention of multi-drug resistant organisms and healthcare-associated infections, such as those in rehabilitation and post-acute long-term care. We have some very interesting IPC topics that intersect in the post-acute long-term care arena. I've created some fictional cases to facilitate the discussion. So let's dive right in with case number 1. In December, a 68-year-old man develops a cough and low-grade fever. He reports nausea and vomiting, and he has new fatigue that's making it difficult to do the things he likes. A nasal swab diagnoses influenza A, and the patient is started on antiviral medication. Our first question I'll pose to Dr. Eber: how do you prepare as respiratory season approaches, and is there a role in using local data to guide any action?
Yeah, that's a great question. Thank you. So first of all, it's really important to educate not only our staff, but our families and our residents, really the whole community, about respiratory season and share that local data. Often I do my education at the nursing stations, And it's really impactful when I say, gosh, we know from our health department that influenza has arrived in Arapahoe County. So it's here today, and that's why we want to be really prescriptive in our infection control processes. Having the education done by a medical director who's a trusted physician and at the nursing stations really invites all of our community into these conversations, and it's really effective. I often start early, like when kids go back to school, we start talking about respiratory season and respiratory hygiene. We want to catch staff members if they have symptoms before they walk in the door. And that's for the protection of our residents and our other staff members, of course. And we want to provide options for staff and family members and patients for masking. We want to make sure that there is no mask shaming, that it's always an option. In general, we know that masking is a huge lift for both our staff and our residents. It really affects the socialization and the sense of home for our residents. So we try to minimize the mandatory component of masking as much as possible. The other thing I do is review the outbreak protocols before the outbreak happens. So early on in respiratory season, I'll get together with our leadership, and the Colorado State had just updated our influenza outbreak protocols, and we reviewed them early on so we know what to do. You don't want to figure that out in the moment of an outbreak. And then, of course, we are always talking early on about vaccination.
Thank you for those great tips. I want to review just quickly about the local data and how that's tracked and managed. So local and state health departments set a list of reportable diseases, and all healthcare facilities and clinicians have to send information when they find one of these diseases. So some easy examples are COVID-19 and influenza, but also things like HIV and hepatitis B. This allows for monitoring at the local level, and then the CDC has a list of notifiable diseases that health departments at the broader level are tasked with reporting to CDC to provide national oversight. So I'll ask maybe Dr. Fitzpatrick, what is your thoughts on the best way to look at or use local data when looking at how facilities should respond during the respiratory season?
Well, it's incredibly helpful to have as much data as you can. And each facility obviously needs to kind of come up with their own way of how they're going to incorporate this data. We don't have necessarily absolute thresholds and absolute criteria in every scenario. So it's a partnership between the medical director, the infection prevention team at the facility, the local health department. But as you mentioned, Erica, there are local resources that are great to help inform when community-based transmission of certain respiratory viruses that are high priority, like flu and RSV and COVID, are reaching higher thresholds and higher rates, because we do know that is a big factor influencing what transmission is going to happen in healthcare facilities and post-acute and long-term care. So the CDC also has some great resources, dashboards monitoring respiratory viral activity that you can filter down by your state, by your age group, things like that. Some resources for inpatients, some resources for outpatients. And so some of that data can be helpful when we're looking at the post-acute long-term care setting. And I really think, building off of what Dr. Eber mentioned, a lot of this is about putting the elements in place before respiratory viral season happens, picking out which data sources you might turn to when you start to see the first cluster of cases in your facility, setting out the criteria for maybe how many cases are going to constitute escalation, where you need to maybe put some additional infection prevention practices in place, what those practices are, and a guideline for maybe when those practices can stop. So having some sort of clear protocols, in the summertime is very helpful. So you're not sort of working on these details in the moment.
Thanks. Dr. Nori, I've heard a lot of discussion there on the importance of communication and transparency. And we know for things like influenza that there is a regular season when we have to be prepared. But every once in a while we get surprised and there's a new pathogen that comes out at a new time. So if we get surprised by, a big RSV season or perhaps a late COVID spike that comes in March, do you have any thoughts or tips that you use when trying to sort of bring new education or new conversations to nurses, techs, other folks in the healthcare system when you're not talking about the same old influenza, but we've got sort of new information to bring around?
Yes, absolutely. Great question, Erica. So as we've seen with COVID-19, it doesn't really follow the same seasonality as RSV or influenza, which tend to be cold weather winter viruses. Although we certainly see increased activity around the holidays and for a few months afterward, like we're kind of experiencing now, it also has surprised us in the summer and the spring, the early fall, et cetera. So the best way to kind of anticipate and predict what is coming our way these days, I would say, are things like CDC wastewater data, rates of hospitalizations, which of course tend to be folks from our facilities because of their comorbidities and their age group, and also deaths, unfortunately, are still happening. And sometimes we can still obtain information like test positivity rate and incidence, things of that nature. But largely these days, it's shifted to these other metrics like wastewater positivity. And so as far as methods of protecting our facility residents, I think in anticipation of those waves, whatever it may be, whatever virus, making sure that our pharmacies are stocked up on preventive vaccines that are age appropriate for our clientele in the facilities, stocking up on antiviral treatments as well. That's a kind of a good preemptive approach. On occasion, we experience shortage of all of these things. And so stocking up in advance is probably the best thing we can do, in my opinion.
That's great. I'd like to shift now to case number 2. This is something that we see a lot in all facility types, but definitely in the post-acute long-term care. A 75-year-old woman just isn't eating as well as usual, and her family feels that she may be a little more confused when they've spoken with her by phone. So they asked the physician at the facility if they would do a urine test to look for a UTI because, in their words, this always happens when she has a urinary tract infection. So what I'd like to do now is, again, start with Dr. Eber. What do you consider in this situation? And I'll then pivot to Dr. Norrie to talk about diagnostic stewardship and how we can bring that in.
Thank you. So first, it's really important to, again, educate not only providers and physicians, but frontline staff and families about asymptomatic bacteriuria, and educate them that we only want to order a UA when the patient meets our criteria. We talk about the dangers of overuse of antibiotics. And what I find is really helpful is even in our admission packets, when our residents are admitted to the facility, we often have a pamphlet about asymptomatic bacteriuria, what is a true UTI and what isn't, and antibiotic stewardship. One of my favorite ones has been created by the University of Rochester. It's one page, both sides, and it's very user-friendly. And then when I'm talking with CNAs and nurses and frontline staff, I find it really helpful to share some statistics. I often say, so if we did a UA on everybody in the nursing home, almost 50% of them would be positive. But of course, they don't all have urinary tract infections. And that puts a lot of things in perspective. And people then realize that ordering a UA automatically for a fall or confusion is not always the right thing to do. So then we talk about the criteria for when do we use and order a UA. I really like the UTI tool created by our Colorado Health Department in collaboration with Telegen, our QIO, and it's really easy to use. And we really want to make sure that everybody's on the same page. So we give it to the nurses and they have it on their nursing cards. And we share the same tool with our providers, our physicians, and even our family members. So everybody knows what the criteria is. And then we review data monthly at our QAPI meeting. We look for trends. So we look at doctor groups. And so we have maybe doctor group A, doctor group B and C. And if we see that one doctor group is ordering a lot of urinalysis that aren't meeting our criteria, that gives us a point where we can intervene. We share our data with the doctor groups. Providers are naturally fairly competitive. And if you see that your doctor group is ordering a lot of UAs, this is a great way to promote some behavioral changes. And then when we look at the information, we want to meet with our doctor groups at least once or twice a year to review our antibiotic stewardship program and how important this is, that this is a priority. Finally, we also want to in-service and educate our nurses and CNAs at the nursing station. And I often go over 5 points with them. I do it more quarterly at least because we have a lot of staff turnover. So it's important to review this information. So we talk about why this is important for patient well-being and why antibiotic stewardship is so important. Then we talk about when we should order UA and where will you find that tool? Where will you find the great resources? And then we talk about how to collaborate with providers and finally how to communicate best with patients and families. One of the most important things to plan ahead is what will we be doing for patients if we're not doing a UA? So we will be monitoring their vital signs, encouraging hydration, monitoring them clinically for signs and symptoms. And this is really how we partner with patients and their families and ensure them that we're providing the highest standard of care. One of the most important lines that I often say is there is no increased risk of sepsis, hospitalization, or death when we do not treat asymptomatic bacteria. And that really is a relieving statement to both nurses and patients and families.
I love the focus that you have on education from the patient and the family all the way to the doctor groups. Dr. Norrie, I know that antibiotic stewardship is a big passion of yours, but so is diagnostic stewardship. So can you describe a little bit about what that is and build a little on what Dr. Eber said about appropriateness of testing and how we can be more judicious in that?
Definitely, it would be my pleasure. So Dr. Eber brought up so many good points, and I love the conversation regarding risk, the conversation validating the symptoms and concerns of the patient and the families, and then also the risk in treating or not treating. So as she stated so nicely, there's no increased risk if we take a watch and wait approach. However, the risk of treating when may not be indicated are certainly very real. And we have lots of good data on that over the years. The elderly population is already at increased risk of multi-drug resistance, especially those who reside in nursing facilities. They are already at risk for things like Clostridium difficile. And by being in this age group, there's an increased risk of death from those conditions. And so while watching and waiting confers no increased risk of death, overtreating and causing additional harms most certainly does confer an increased risk of death. And so I really like the strategy of having this conversation based on risk. And that's certainly something that I learned today, and I'm going to adopt in my own practice. Thank you, Dr. Eber.
Things and a lot of the resources that Dr. Eber mentioned will be in the resources tab, the UTI tools, some of the patient and family education information that she discussed. And another resource that we're going to have that Dr. Fitzpatrick has shared is a tool to look at when to appropriately, with confusion, when to check for UTIs in elderly and when not to. Dr. Fitzpatrick, can you talk a little bit about the tool for looking at true delirium?
Absolutely. As Dr. Eber so eloquently, described, a lot of changes in people in post-acute long-term care are relatively nonspecific. It might be behavioral changes or changes in activity level. And maybe just a fall or something like that. So what we collectively refer to as non-localizing signs and symptoms are very difficult to interpret and certainly prompt a significant amount of probably inappropriate urine testing, which leads to downstream inappropriate antibiotic use. So the Society for Healthcare Epidemiology of America has put together some guidelines for certain signs and symptoms, how to get better clarity and sort of specificity on whether those truly indicate a concern for infection or whether they could be, as Dr. Nori mentioned, more appropriately managed with cautious, watchful waiting, more frequent vital signs checks, things like that. And so for behavior changes and sort of non-specific mental status changes in particular, these guidelines really do recommend using a tool called the CAM, the Confusion Assessment Method. And there are some great calculators and sort of simple toolkits that can be used at the bedside to assess if a patient actually has some of these more specific signs and symptoms of true delirium. And that can be a very helpful thing to implement maybe amongst your bundle of interventions, including education and targeting patients and families with education. You might be able to incorporate some of these easy bedside assessment tools for your nurses and other providers. So it's a great resource.
Thanks. I think it's always great to offer folks, the hard copy, so to speak, of what we discuss here. And it's always nice to be able to take a handout back to your facility and say, hey, can we use this at all in our day-to-day patient care? So thanks to the three of you for sharing those resources with our audience today. Our last case number 3, a new nurse at your facility asks if you will be providing influenza vaccines come fall. She lives with her elderly grandmother and worries about bringing the flu virus home to her. So this case is a great reminder that vaccine hesitancy is real, but a lot of healthcare professionals do look forward to and rely on the protection that vaccines provide. So let's start with Dr. Eber. How do you address both vaccination goals that your facility or your state or local jurisdiction might have, and then also looking at how to advocate for vaccines for your residents?
Yeah, thank you. Vaccine hesitancy in education is a passion of mine. So we know, of course, that vaccines are essential to decrease mortality and morbidity in post-acute and long-term care. But these vaccine conversations can be kind of difficult these days. It's not the first on everybody's wish list. So, of course, in post-acute and long-term care, we have 2 groups. We have residents and then we have staff. And their strategies can be a little bit different, but the foundation is still the same, and it's always based on trust. Trust, of course, is built and earned. We have to demonstrate that we are trustworthy. One of the things we learned from the pandemic that it's really essential to be honest and transparent. Say what we don't know. We may not know if the COVID-19 vaccine is going to be absolutely a yearly vaccine that we'll want to recommend. So that's something that we're working on. But when we're transparent, then we build trust. And we also want to invest in relationships. People want to know that we have their best interest at heart. And that also is a way to build trust. And then finding common ground. What do we agree upon? We all want our residents and our families and our coworkers to be safe and healthy. And that's where we can start. So for residents, I have 3 pearls that I use. First of all, assume the answer is yes. If you see Mrs. Jones and she is due for her influenza vaccine, we can say, "Hi, Mrs. Jones, it's great to see you. I see you're due for your influenza vaccine, and I can order that for you today. We have it here in the facility." Number 2 is to listen and with respect and answer questions, leading with empathy. We want to really find that trusting common ground and build that relationship because that's the best way towards vaccination. And then we want to emphasize the benefits. We know that COVID-19 vaccines and influenza vaccines, RSV vaccines, provide enormous protection. Even if you get the illness, it's going to be less severe. And most importantly, we can really seriously prevent hospitalization, ventilator needs, and death. So the benefits are many. When we're talking with staff, I have some different strategies, and I thought I'd share with you 6 of them. First of all, make it easy, offer it at work, so it's right there. To use an open door policy to answer questions. Sometimes people are nervous about asking questions. I've had some staff members write them on a card and give them to the administrator, and that's how I answer them. And lead by example. Share your own vaccine story. I often talk about my kids. I have a 22-year-old son and a 25-year-old daughter, and the process I went through about deciding that it was really important for them to get vaccinated for influenza and COVID-19. Make it personal. I have not met yet Dr. Kimberly Manning, but I'm a huge fan. And I love it when she says, don't just wag your finger and demand that people get vaccinated. That doesn't work. We know that fear and shame are not pathways towards vaccination. Nobody wants to feel that way. So we want to promote the positive and activate our staff's agency. We want to appeal to their expertise, their pride, and their purpose, the ability to affect and improve our community. And ensure staff that if they have side effects, it's very helpful that they know that they don't have to use PTO to recover from a vaccine side effect. So in thinking about incentives, this is our number 5, it's a plus and a minus. We know that incentives in post-acute and long-term care are useful if they're meaningful. So some of the incentives that I've found to be useful is some bonus PTO time, so that there is a benefit, additional benefit to vaccination. And then we use social norm influences to influence human behavior. So if you have a CNA or a nurse that you know is very respected, everybody looks up to, ask them if they'll partner with you and share their vaccine story. Why did they get vaccinated? And talk to folks who may be apprehensive. Also, you can use FOMO, fear of missing out, to your advantage, of course, and then highlight how you're doing as a facility. We hope to have 80% of our staff vaccinated. We know that that will decrease our risk of outbreaks. And outbreaks are a big lift in post-acute and long-term care. So if we can do it together, people can join us, and that feels really great.
Thanks for those excellent tips. FOMO is definitely something that most people will respond to, and definitely getting folks that are looked upon highly to come and join you in your campaign. Dr. Fitzpatrick, what's your approach, I should say, in when you promote vaccination? So those of us who are infectious disease doctors probably deal with this a lot. I know in my HIV clinic, I feel like almost every patient I'm talking about pneumococcal vaccines or various other vaccines, even throughout the year that folks need, not just during the the respiratory season. How do you approach those conversations with patients in trying to educate them and answer questions?
Yeah, I do a lot of vaccine counseling. Absolutely. And one of the things I think that really resonated that Dr. Eber mentioned was sort of approaching with respect and empathy. And I think building upon that, one thing I have learned through trial and error is that you do have to have patience and sort of a long-term goal with a lot of patients. And I would imagine this applies to staff too, whereby not having an expectation that one conversation or one encounter is necessarily going to completely overcome concerns or hesitancy about vaccines, but having a plan that you're going to have several conversations or potentially over a span of a couple of visits with a patient, sort of tackle it in chunks. And then over the course of having more time, providing education at each visit, bringing it up just over and over again. I mean, I've had many, many patients get to a point where we can reach a common goal of them getting vaccinated because I just kept bringing it up and kept talking about it. And so I think patience and kind of having a long range plan can be very successful for people who have some concerns and hesitancy about vaccination.
Dr. Nouri, if we sort of step back a little bit from individual patient interactions and look at maybe a hospital or a hospital system and trying to increase staff vaccination participation, any thoughts or experiences that you've had in sort of that maybe larger scale education campaign?
Definitely. Great question. So the first thing I would say is that this is all falls under the regulatory umbrella. So we do have to report things like rates of employee vaccination, rates of employee illness from these vaccine preventable illnesses, et cetera. One thing that I have found that has been a very motivational tool from our occupational health services is unit by unit competition, so to speak, or children's hospital versus adult, or this campus versus that, and it helps to motivate folks. Another thing I'll add from my own clinical practice is that if we try to bundle all these vaccines together, it may be overwhelming. So we had influenza for a long, long time, and then suddenly we had the COVID vaccine as of late 2020, 2021, and then now we also have the RSV vaccine, and we only get so many shots, so to speak, to encounters to either educate or deliver these vaccines to personnel in facilities or patients. But if you come at them with 3 in one on one day or 2 on one day, while it may be convenient, it may just be a lot of information at once. So I personally find that taking it in bite sizes might be better. So for instance, I might say, let's definitely do the flu today because that's the one you're at highest risk for. That's what's circulating the most in the community. RSV is brand new. I understand if you want to take some time to think about it. After all, ACIP recommends shared decision-making around that in order to determine whether or not to administer. And of course, I'm glad you got the COVID shots that you got, but let's perhaps make some time to talk at your next visit about the newer monovalent vaccine. So taking it in bite sizes, I think, is my approach.
No, I think that's helpful. I think it's overwhelming for us as physicians to have to learn about new vaccines and the side effects and how to give them and when to give them, and then to just be able to throw that at patients in the same manner is definitely overwhelming. So thank you for sharing that, and also for talking about that we have to report those rates of vaccination and vaccine preventable illnesses. I didn't realize that those were things that were tracked, and so I thank you for helping me learn something new today. I want to thank Dr. Eber for sharing her experience with us, and thank you also to Dr. Norrie and Dr. Fitzpatrick for providing information on how to look at infection prevention in this unique setting. Thank you to the audience for joining us today. We've hope that you've learned a little bit more about meeting IPC challenges in post-acute long-term care facilities, and we hope to see you at other building block sessions.